Hi, everyone. Welcome to the Sports Docs podcast. On each episode, we chat about the most recent developments in sports medicine with experts from around the country. Today, we're coming to you live from the 10th Annual Arthrex Team Physician Controversy Conference in Naples, Florida. I'm Dr. Ashley Bassett.
And I'm Dr. Catherine Logan. So Team Physician Controversies is a 2-day conference that brings together world-class orthopedic surgeons in professional and college sports. And we're going to discuss patient diagnoses, treatment, return to sport management through case-based presentations. We're fortunate enough to have the opportunity to catch up with many of our esteemed colleagues and faculty at this meeting and talk about some cutting-edge sports medicine topics.
We're joined today by Dr. Kevin Farmer, a shoulder and sports medicine surgeon with extensive experience managing shoulder instability in high-demand athletes. He is a professor of orthopedic surgery at the University of Florida and a team physician for the University of Florida Gators. Dr. Farmer, welcome back to the show.
Thank you for having me.
We're happy to have you. So today we're going to be diving into every sports and shoulder surgeon, something we deal with very regularly, traumatic anterior shoulder instability. So with a specific focus on surgical decision-making as well as our technique. So we're going to chat about when to operate, who to operate on. We're going to talk about when should we add remplissage, as well as what should we do with Hill-Sachs engaging lesions.
Yeah, so this is a great topic, and there's been a real evolution in how we think about instability, especially early surgical intervention and bipolar bone loss. So let's get started. So kicking off with the classic question of who really needs surgery. So obviously patients with recurrent instability are going for surgery, but what about first-time dislocators? So Kevin, what factors are you weighing deciding on surgical versus non-surgical treatment for a first-time shoulder dislocation?
Yeah, it's a great question. And certainly we know from the military and the athletic population that the risk of recurrence is obviously the biggest concern at, with rates anywhere 80 to 90%. And so what can we do to minimize that? Because we also know that the second and third dislocation increases your risk of not having as good of an outcome. And so, certainly for me, a younger patient, so age less than 20, an active patient, especially collision athletes, football, basketball, wrestling, those kind of athletics, those are going to be the high risk. Males have a little bit higher risk than females, but that doesn't really go into the decision making per se. For me, it's age and level of activity are the biggest things. And then certainly get into the other aspects of it when you look at radiographic imaging, bone loss, and all those things. But on the patient aspect, I'm looking at how young are they and how active are they, because that's going to be the highest risk group.
Perfect. I think those are all great things to consider. And you'd spoken about the patient sort of identifiers and briefly start to talk about MRI and imaging. So let's talk about that. So the data increasingly supports early stabilization can be helpful to reduce recurrent instability, secondary bone loss, as well as loss of time from sport. So let's move on to imaging. Obviously, we're going to get an MRI, but I want to talk a little bit about CT and 3D reconstruction and how that fits into your practice. So can you talk a little bit about that, Kevin?
Yeah, I mean, certainly with a first-time dislocator, and 90% of the time, an X-ray and MRI for me is going to be adequate. But if I get into that case where the MRI looks like he's got either a large bony Bankart or a large engaging Hill-Sachs, and I really want to quantify what that is, then I'll get a CT. Revisions, I'll get CTs. But really what it boils down to me on that sagittal image, when I look kind of at the side of the glenoid, if I see some anterior bone loss and I'm worried that it's going to be in that 15% range or greater, then I really want to quantify that better. I'll get a CT and a 3D CT and then look at perfect circles and do the analysis and all those different things.
Yeah, so you mentioned there about that bone loss, critical bone loss versus subcritical. So in the absence of critical bone loss, arthroscopy still really is the mainstay of treatment. And modern arthroscopy techniques with knotless anchors have really improved reproducibility and efficiency. So let's start there. So Kevin, how has your surgical approach and choice of anchors evolved over time from the start of your practice to what you're using today?
Yeah, no, that's a great question. When I was a fellow, we were using larger anchors and, I think they're 2.4, 2.5 millimeters. And I remember seeing some recurrences and they would get this postage stamp for me. They'd fracture through the anterior glenoid and you would see the anchor sites. And it made me start thinking, are we putting in something that's putting that risk for this happening? So my first couple of years in practice, we did a biomechanical study where we put in different anchors and we found that the difference between a 1.8 anchor and a 2.4 was significant as far as the threshold to bony Bankart creation. So early on, I started thinking about how can we get to a point where we can put smaller anchors. And in addition, if you look at the healing of a labrum, having spot welds, basically like in metal welding, spot welds is really heal, in my opinion. So having multiple sites of fixation, I think, increases your ability to heal. And so you can only do that with smaller anchors. That's the first thing. Having smaller anchors, now we have 1.6, 1.8, so much smaller footprints as far as bone loss. I do the combine every year, and I see a lot of players come through, a lot of Alabama players. Lyle Kane's been using these anchors for a long time, and you really see, bone formation in these small little sockets. And so the biomechanical aspect of smaller anchors and multiple spot wells and not increasing your risk of bony Bankart, I think, is number one in these contact athletes. Number two is getting strong fixation, quick fixation. So not having to sit there and tie knots and leaving a knot stack that over time can migrate into the articular surface. We've all seen patients, we go back in for a scope and you think the knot was placed off the surface and you get it in there and it's near the cartilage or causing some irritation. So having knotless fixation, not worry about knot stacks, especially a throwing athlete or something where you're worrying about posteriorly, I think that's critical. And then alternating between simples. I alternate in simples and mattress stitches because that gives you a nice footprint. The simples kind of recreate that bumper, whereas the mattress really get a good compression of the capsular labral kind of complex against that bleeding bone. And so to me, the smaller anchors, the knotless mechanism, all suture base really kind of hits all those things that I look at in these athletes. And I think why we're seeing, in my opinion, a little bit of a decrease of these recurrences because of those changes over the last 15 years.
Yeah, I think, Kevin, that's excellent. And, to summarize, I think those FiberTech anchors, they're smaller. So, we're thinking about minimal bone removal. We're also, it's knotless. So we are not thinking about those stacks, obviously, as you said, in the throwing athlete. And then you mentioned how we deal with the capsule. So mobilization of the labrum as well as, dealing with the capsule. We know that if we're not doing these things well, that sometimes we're also increasing our risk for failure. So talk a little bit about, how do you deal with the capsule? Are you doing a shift? What kind of techniques are you using?
Yeah, that's really the artistry of instability surgery. Why I like instability surgery so much, because it's such an individualized approach. If you take a big offensive lineman that doesn't need to be up here in space, I want to maximize the amount of stability and not have a recurrence. So I'm going to do as much of a shift as possible. And I'm really freeing that up down to the 5:30, 6 o'clock position, taking a kingfisher, making sure I can mobilize it way up to the face. And so I'm going to maximize that as much as I can. Now, a skill athlete like a wide receiver or a defensive back, they do need to get their arms in space. And so maybe I don't want to do that quite as tight, but I also don't want to pop out again on national TV. So you got to find that, that kind of happy space, the happy medium where you stabilize them, but you don't adversely affect their what they need to do. And so that's why I think instability surgery is such a fun area for us to work in, because it really is an art form as you approach each individual athlete. A throwing athlete, you want to stabilize them but not tighten them too much, all those different things. Yeah, but every patient I mobilize all the way down to the 5:30, 6 o'clock position, make sure they can get that at least back to where I think it should go. And then if not, even more in an athlete that I'm not worried about having their arm up in space. And I also always put anchors posteriorly, so we can get into that. But every one of them is going to have, I believe in the circle concept that Russ Warren discussed 30 years ago, that even though it's a traumatic anterior instability, you still get the hammock, the sling gets affected all the way around the inferior glenoid. And so I always believe that you have to recreate that hammock on both sides. Obviously, you're worried about most anteriorly, but I think if you just approach the anterior side and neglect the posterior side, that you're not truly recreating that normal tension that they had prior to the incident.
Yeah, so that kind of gets to our number of anchors. So as you mentioned, the benefit of these smaller anchors is that you can fit more of them. It's not just 3 and you've run out of real estate. So there's been a lot of literature, older literature, looking at number of anchors and risk of recurrence. So how many anchors are you aiming to place anteriorly, but also can you speak a little bit about posteriorly as well?
Yep. Yeah, you're referring to Pascal Bolo's work where they showed that 3 anchors, less than 3 had a higher incidence recurrence, and so that is certainly a minimum. But now with the smaller anchors, I think in most cases I'm putting 4 to 5 anteriorly, and then around the back, starting at the 6:30, 7 o'clock position, I'll probably put 2 or 3. Just if you think about again that anatomy of the anterior band and the posterior band, what's that footprint? I'm trying to recreate that footprint on both sides, and that comes all the way to the 3 o'clock position anteriorly and up to like 9 o'clock posterior. So I think you've got to recreate both sides in there. So in most cases, for me, a contact athlete's going to be a minimum 4 in the front, 2 to 3 in the back, and then 2 for the remplissage. And that's a typical contact athlete instability surgery for me.
Perfect. And once you place these anchors, Arthrex has different solutions for suture passage devices. So let's talk a little bit about suture lassos. Obviously they come in many different shapes and configurations. How do you incorporate this and how do you choose?
Yeah, for the most part, the 25s are my workhorse. So almost every case, it's going to be a 25 left, 25 right, have those opened. And I don't know that I've ever really had to go too much away from that. That seems to work in every case, but certainly the other options available if you're comfortable with different angles and rotations. But for me, the 25 left and right, I can get 99% of my cases with that.
Now, you mentioned anchors for remplissage, so let's talk a little bit more about that. So for our listeners, historically, remplissage was reserved for significant off-track Hill-Sachs lesions, but now there's kind of a growing interest in using it in borderline cases, particularly in high-risk patients. So can you talk us through your indications to add a remplissage procedure? Are you ever adding it prophylactically in borderline cases? What's your thought process there?
Yeah, my indication at this point is pretty much every case, I would say. But with that being said, we got level 1 evidence that the addition of remplissage decreases your risk of recurrence. Again, in these high-profile athletes, that is the number one thing we're trying to prevent. And so, it used to be historically we'd worry about loss of motion. That's kind of borne out to not be an issue. Throwing athlete, overhead athlete, then certainly you take that into account and kind of weigh the pros and the cons. But in a non-overhead athlete, contact athlete, pretty much all of them in my practice will get a remplissage. I see no downside to it, and there's plenty of upside. It's so easy to do now with the technology we have with the fiber tacks and doing the kind of the crossing fixation. It's just so quick and easy. You do percutaneous, we can go through the technique, but I don't even go to the subacromial space. It maybe takes 5 minutes to do, and we have level 1 evidence that it decreases that risk of recurrence. And again, that is the thing we're most concerned about.
Yeah, Kevin, you're absolutely right. We do want to dive into the technique. So let's talk a little bit about when in the surgery do you perform or, place the anchors, how many anchors. So dive into that a little bit.
Yeah, I probably make it too hard on myself. If you look at a lot of people put their anchors right away because you can see it best. And that makes sense to me. So my approach has always been fix anteriorly, fix posteriorly, do the remplissage, close the posterior capsule if you think about doing that, and then you're done. So I wait until the end, and it really has not been an issue. I have to avoid the resident or someone pushing too hard anteriorly to try to see. So I'm always careful. I'm always giving counter pressure as we're drilling and passing. But I do it at the end. I do, Pat Denard's kind of percutaneous technique to put them in. And again, I don't have an issue with that. But if you're having trouble seeing, doing them right away and then kind of taking your sutures outside the cannula and putting it in is also a very reasonable approach. I just like to get it all done and avoid suture kind of crossover, and so I do it at the end.
Now, as you highlighted, the data really highlights the benefit of adding remplissage in terms of lessening instability, but something that we hear about from surgeons is a concern for loss of motion, which is the loss of external rotation. Now, you just mentioned there that it's maybe overstated, but can you talk a little bit about where these concerns came from and perhaps technical changes that led to a decreased risk of loss of motion?
Yeah, you are obviously tensioning the capsule posteriorly when you do that. So loss of external and potentially loss of internal because of that. But the studies really show it to be minimum. I don't know if it's a technique issue, just other than the fact that just borne out through follow-up studies that it really didn't have that effect. Now, again, if it's a quarterback or a pitcher, I've had a handful of high-level Olympic-level swimmers that really need to get that mobility, and maybe they have a small remplissage. And a football player, 100% is getting a small Hill-Sachs, and a football player, 100% getting a remplissage. And that swimmer, I probably would avoid it just because maybe a 5-degree motion loss wouldn't affect that other athlete, but that could affect an Olympic swimmer. So you have to consider that a little bit. But really, the overall issue with it, I think, that was thought of early on, it really never bore out to be a major problem.
Great. Yeah, and as you said, it's a little bit of an art, and that's one of the really exciting parts about shoulder instability surgery. So one of the last things we do want to touch on is rehab and recovery. So can you walk us through a little bit your rehab protocol and how you handle these athletes, and do you change when there's a remplissage?
Yeah, we get them going the next day. So I see them all in therapy the next day and go over the plan. it's pretty rare for me to hold them or go slow unless there's some tenuous issue. The capsule maybe wasn't as robust as I'd liked or something like that. But or multi-directional instability, that one I'll go slow with. But in a contact traumatic instability, they get started right away, working on range of motion and scaption, obviously avoiding the issues that put stress on the repair. The only change with the remplissage is we avoid isometric rotator cuff strengthening, which is usually part of the process early on. You want to avoid that kind of infraspinatus kind of isometric strengthening they do typically. I think we start that around 6 or 8 weeks. So that's the only change we have is the strengthening early on.
Makes sense.
Now, lastly, we want to wrap up with a discussion on safe return to play. And there's been growing interest in using a criteria-based analysis to safely clear someone, similar to what we do for ACL tears, looking at, dynamic shoulder stability, strength assessment, motion, all of that. So you take care of a lot of contact athletes, a lot of football players. How are you determining that they're safe to get back into sport after this surgery?
Yeah, we would do isometric testing. I don't know that there's a hard and fast rule how to use that, but we try to get that within, 20% of the good side. Obviously, physical examination, you'd like to have a negative apprehension. Most of it's a time-based criteria. If they've kind of passed their range of motion PT criteria, for us, 4 months return to non-contact. So I did probably 5 after the season. We played Florida State on the 30th of November, Monday after Thanksgiving. I did probably 5 that day. And so the goal is to have them all back for spring. We got a new coach, new defensive plan, offensive plan. We need to have them available. So the goal is to have all of them back for the spring, but no contact. And so, but you got to watch that closely because you give the coaches an inch, they'll take a mile. And so you got to have good athletic trainers that can manage that because you put them out there, no contact, and they're having them run blitzes and do all these things. Next thing you know, you're putting it at risk. So typically, actually, they're 2 months now, so we got them back to running, which is a little bit quick. But I'm so comfortable now with the strength of fixation that I used to wait till 3 months to run. Now we get them running at 2 months, so they're all back to workouts now, running. At 3 months, we'll start progressing with the weight room and those kind of things. At 4 months, return to no contact. Ideally, if you can hold off to contact to 6 months, which should work out if we can get through the spring, then that's kind of the ideal setup. Now, in some cases, if you push a little bit because let's say you have surgery and you guys are team's doing well and you make the playoffs and all these different things, I can be okay getting somebody back at 4 or 5 months, but I would have more harness where a sully, where different things are protected, and I'd lay a lot of crepe. They have to know there are some risks for going back too soon, and they have to be able to make an informed decision on whether or not they want to take those risks.
Yeah, absolutely. And, I think that's why it's so nice to take care of athletes. You really are designing it individually for them and, their position, their team, and, working together to find the best solution. So this has been a fantastic discussion. We love having you on the show. Obviously, we've had you on before.
Thank you.
Kevin, thank you.
Yeah, no, this is great. Yeah. You guys are big time now. This is awesome. Congratulations.
Thank you.
Thank you.
And thank you for listening to this episode of the Sports Docs Podcast live from the Arthrex Team Physician Controversy Conference. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and YouTube. Until next time.